Right. Well, welcome everyone. Happy Friday. And I think that you will be very happy that you chose to spend some time with us on this Friday morning or afternoon, wherever you are, to hear some stories from the field when it comes to putting reliability and resilience into action in our hospitals here. And I'm just really grateful that you're here. I'm Kim Workmeister. I'm the Senior Vice President for Improvement and Implementation at Convergence Health. And today we have an incredible panel for you. A little bit of a history for where this series came from. Back in December, CMS put on this wonderful HRO day. And this was made up of speakers from across the 9 different HQIC contractors. And we had about 6 hours, I want to say, of presentation after presentation, presentation. And not many hospitals were able to join those. And all of us in the HQIC contractor role thought, oh my goodness, there's such incredible information out here. We want to make sure that there's an opportunity for hospitals to be able to listen and learn and participate in these learning sessions. So we decided to take that HRO day and break it into much smaller bites so that it was so it was possible for folks to participate. And Helen, if you can go to the next slide then too, I'll walk through a little bit about what we wanted to do with this. So we wanted to make sure that we have an opportunity to discuss the foundations, theories, and applications of resilience and high reliability organizing in healthcare. Really wanted to spend some time describing the practical implementation strategies for activities that promote reliability and resilience, plus any tools or resources available to healthcare organizations. And then start to think through what might be one idea to test at the local level to address reliability and resilience. And today, I think you will hear some of those great ideas because if you go to the next slide, I'll walk through where we've been. So we started with there are 3 components of the series. There's a foundational knowledge piece, and those ones we put into sort of a self-study piece. We sent out some recordings and some resources that were from the first part of the HRO day. So Dr. Oren Gutman from Jefferson Health and the Hades or HQIC had a phenomenal presentation on resiliency, engineering, and human factors as a path to high reliability organizing. If you have not had an opportunity to listen to that recording, or at least to review the slides, but really listen to the recording, I highly recommend that. It is just really wonderful information there too. And there's links in the slides, which we will send out after this. And then from our HQIC from Convergence, Dr. Bruce Spurlock had led we called it it was an executive roundtable, called it Leading in Tough Times, and built a resilience playbook from this too. And so would love for you to review that playbook. Goes into a lot of these, sort of high level thinking and then getting down into the practical side of using these foundational concepts in a hospital setting. You go to the next slide. Then we went to our second component. And this was the practical application of resilience and reliability at scale, so larger sizes. And that was in April. We had Risa Hayes from Telegen HQIC and Jen Murphy from HQI HQIC, who both presented some really great practical in-depth approaches to building high reliability, implementing an incident decision tree, a la Just Culture too, which is a really good component of high reliability. So those slides and recording are also available to you. You'll be able to just go directly to the link here when you receive these slides. And then if you can go to the next slide, that brings us to today. I'm gonna sure that everyone make sure your lines are muted for this. That brings us to today. This is where the rubber really meets the road and we get to that actual implementation at the hospital level. And we have this hospital panel discussion. When I heard it the first time, I just thought, oh my goodness, this is exactly what folks need to be able to hear. It's a really friendly discussion about how we implement high reliability practices and ideas and foundations in the hospital setting, and very particularly in a critical access setting. And we were talking about this before earlier today, that a lot of times we think about these big concepts for high reliability, and we think about them being something that is implemented in really big organizations. But truly, critical access hospitals and smaller hospitals have such an edge over these larger organizations when it comes to building reliability into all of your practices. We don't have to worry about the multiple levels of bureaucracy. We can really get down to what reliability means when it comes to providing care in a critical access hospital. So I am just so thrilled to introduce you to our panel today. So if you go to the next slide, we're going to be talking about applying HRO concepts in critical access hospitals through the Compass Hospital Quality Improvement contract here. On the next slide, let me introduce you to our wonderful panel. So Julie Noah has 28 years of nursing experience. She began her career in medical surgical with a large portion of her career working in the emergency department, starting with a one-room ER in Clarinda, Iowa. Her healthcare leadership path started in 2012 at Boone Health in Columbia, Missouri, on the surgical floor as a clinical supervisor. She enjoyed working with many teams as a medical surgical manager, peri-anesthesia manager, chief quality officer, and chief nursing officer in hospitals throughout Central and North Missouri. Jennifer Newton is the chief nursing officer at Neosho Memorial Regional Medical Center. As a chief nursing officer, she's responsible for overseeing operations for all nursing departments at the medical center, including ER, ICU, med-surg, OB surgery, outpatient surgery, infusion center, and case management. Neosho Memorial Regional Medical Center has been named one of the best places to work since 2009. And Jennifer received her undergraduate education at Pittsburgh State University and her master's in nursing administration from the University of Kansas. She is certified in lean healthcare from Belmont University and has been in her chief nursing role for 19 years. As the CNO, it's her responsibility to work to provide high reliability concepts within the nursing department. And Neosho Memorial Regional Medical Center was listed in Becker's review as one of the top 350 hospitals for nurse communication in 2022. That's excellent. Finally, I'd like to introduce you to Julia Pyle. Julia joined Kansas Healthcare Collaborative, or KHC, in April 2022 as a quality improvement advisor. She provides consultation and quality improvement support to hospitals and other healthcare organizations across the state, collaborating with KHC in quality and patient safety initiatives. Through coaching, technical assistance, and engaging with healthcare leaders, Julia provides support for improvement related to safe patient care. In her role, she draws on continuous improvement methodologies and operational clinical expertise to analyze and influence improvement using evidence-based practices. Julia brings more than 30 years of progressive experience in the healthcare industry with a background that includes critical care, education, supervisory, and executive leadership roles. Julia has been a leader in bringing high reliability concepts and evidence-based practices into hospitals to ensure delivery of high quality care and excellent customer satisfaction. Julia completed her undergraduate degree at Pittsburgh State University before receiving her Master of Science degree at University of Missouri in Kansas City. So with that, I'm going to turn over. I'm going to have each, Julie and Jennifer will tell you a little bit about their organizations, and then we'll get into this panel interview. So let's go to the next slide. So, Julie, I would love for you to introduce Clay Center Medical Center to us.
So, yeah. Can you hear me?
Yeah.
Okay. Yes, we're Clay County Medical Center in Clay Center, Kansas, and we are a 25-bed critical access hospital. Since our slide, we actually are adding on mental health providers and APRNs as we go. So we have a total of 16 providers now. We do have over 300 staff members with growing outpatient clinics as we go. We do have a full service laboratory. We've got emergency obstetrics. We do deliver about 60 to 70 babies a year. We do outpatient surgery and same day surgery. We do have a new MRI. We have ultrasound, CAT scan, and mammography in our radiology unit as well. We do have a rural health clinic that's connected to our hospital, and we see around, we have around 15,000 patients. That rural health clinic also has 4 satellite clinics in surrounding areas as well. We have cardiac rehab and respiratory, PT, OT, and speech. So a little bit of everything. I think we do a pretty good job of offering the things that are needed to our county, and always, just like all of you, looking to grow and do better. So
Thank you. Let's go to the next slide too, because I'd love to have Jennifer get a chance to tell us a little bit about her organization too.
Yes, so hello, I'm Jennifer Newton. I'm the Chief Nursing Officer in Yiddish Memorial Regional Medical Center in Chinook, Kansas. So it is, we're located in Southeast Kansas, and we primarily serve around a radius of 30 miles from our hospital. That's our primary service market. We do have rural health care providers, as you can see, associated with our facility as well. We do have a rural health clinic that the hospital owns, and we work with a multi-specialty group physician clinic that is just next door to us. So I think she kind of announced or talked about all the services that we offer. So in our ER, we see about between 10 and 11,000 patients annually. Our OB, we deliver between 340 to 380 babies per year. So still pretty big in the obstetrical arena. And then we do have a large outpatient surgery volume. Those are probably our areas where we kind of bring a lot of individuals in. We have a urologist, OBGYN, general surgery. We also have a specialty hand surgeon here at Yiddish Memorial. So that brings individuals and kind of draws that market as well for those upper extremity orthopedics. Just like Julie said, we have very similar services. One of the areas I think we do see even growing is just those outpatient services. So cardiac rehab and those things that just community members want to come back to their critical access hospital to receive care in their own community, especially for things like that. So do a lot of imaging studies as well here. So very, very similar to what Julie described. We do have a little over 400 staff members here. That's with our surrounding services, with our physical therapy and things like that. So yep, very, very much alike.
Wonderful, wonderful. Well, why don't we go to the next slide, and I am going to turn over the conversation to Julia for this panel discussion. So Julia, take it away.
All right. Well, thank you, Kim. I'm really excited to have both Jennifer and Julie here today sharing their experiences and how they have operationalized high reliability concepts in the critical care space or in the critical access space. So we're going to just jump right in, and we'll start with our first question here is, can you kind of help us understand what was the impetus for starting on the high reliability journey in your organizations? And were you calling it high reliability at the time?
I'll go ahead and jump in with that first question. So no, we were not actually calling it high reliability at the time. You know, kind of when we started on this journey to error is human is kind of the report that came out, and we really were looking on, you know, how do we standardize the work that we do, and how do we, you know, look at reduction of harm, and just, you know, kind of have the best practices that we can within an organization. So we called it kind of our journey towards excellence and chasing zero. We had a huge committee that kind of worked together, is kind of what we talked about it. And so I think, you know, then it was just looking at practices that we could do to standardize things. So several members of our organization then became lean certified. So our CMO at the time, our CEO, myself, our quality director, then we added finance and actually kind of a lean coordinator that got trained. And I think a lot of those lean principles, you know, align with high reliability organizations, because they just give you some tools that are pretty practical to be able to use to kind of drill down to standard work and looking at some of those things. So we did a lot kind of with that. And then just adding some different, what I call like special service things that we did with adding, rounding and different tools. And we'll kind of talk more about that as we go with validation tools to our journey. But we did not present it as an HR, like a high reliability organization to our staff. It was just, a pursuit of excellence for us.
Very good.
Mhm.
Julie, do you want to share a little bit about what that looked like in your experience?
Yes. So we do not call it high reliability either, and really are just starting on the journey, probably not as far along as Jennifer and her team. I've just been here a little over 2.5 years and had some turnover in our quality department. So really educating our staff and providers, similar to what Jennifer said, in what is excellence, and where are our opportunities to provide better care or better outcomes. So a lot of that also right now where we're at is digging into data that we have to report, and what does that mean and how can we utilize it. So that's where we're at. Also, the providers over the last 2.5 years, again, bringing them data and really just digging into it and letting them ask the questions and say, why does this matter to me? And then small wins really is our big thing where we are starting, because we want to show that quality is your friend, I guess is what I want to say. And we're not only coming to find you when things are wrong, we're coming to say, okay, this is what you're telling me, or this is what happened, and I can help you with all the things in the background that I know. So it's really, like I said, that big picture. And so right now also our department managers are working together, looking at our strategic plan. As we talked about with critical access hospitals, outpatient is the way of the future. So we have to change and grow as well. And so what does that look like for us? That's where we're at.
Very good. So, when we talk about key stakeholders, can you talk about who do you engage in a journey like this? Is it department level directors? Is it, your entire organization of leaders? Is it your community? What does that look like for engaging those key stakeholders?
Yes, I'd be happy to take that one as well. So, for us here, it's everyone within the medical center. It starts at a high level with senior leaders. We all have what we call like our a scorecard. And so we are a 5-pillar scorecard. So we focus on service, people, quality, growth, and finance. And so each one of us has kind of the same organizational goals, but we have different weights for each person. So for example, I have a higher weight on service and quality. And then, the CEO is more kind of balanced. So we each kind of have kind of our area of specialty. And from that, then our department directors, they take some like cascading goals or some goals from, specific service goals that more impact them at their level of their department. And then when we do our hospital evaluations, part of my score for nursing and then their department manager's score goes towards how we do with our performance evaluation. So everybody has a vested interest in the overall operational goals for the hospital. So definitely at a high level. And then, we do a lot of things like I kind of talked about with kind of lean and those principles to kind of help us navigate, how do we improve a service, or how do we look at the details of kind of the event in a process. So we do training to all of our employees as they onboard. We do a quarterly training with lean. And so they understand those principles and know kind of the tools to use and can talk with their manager when they see that things maybe aren't kind of operationally where they want them to be. And so we do a lot of things like that where we bring kind of the employees in and engage them with that journey.
Very good. And Julie, I'll give you a chance.
Yeah, so so we are a little, like I said, again, just a little bit behind Jennifer, but we are starting to utilize some of those same lean principles. But where I think we excel is everyone in their department looks at quality and is always looking at improvement. And I think we have the opportunity to not be as siloed. So we've come together and we talk about it. And so everyone's learning, like I said, that a lot of the times their quality improvement projects are affecting others in a good way. So so that's where we are. And we've used some lean tools. We're starting with medication reconciliation, which sounds crazy, I know. And we actually just recently did a report to our board about medication reconciliation, and it was very eye-opening to them, all of the caveats, I should say, of med rec.
Yeah.
And so anyway, we are like I said, right behind Jennifer on her tail, really just kind of working towards those same things, and everyone is a stakeholder, true.
Yes.
And I think that saying that out loud every day is the most important thing. And like I said, we continue to fight that battle, I guess, really right now.
Yes. Yeah. And I think you both bring up a really good point in that you really can't integrate what isn't aligned. And so aligning goals, taking that strategic plan and making it real, not just creating a strategic plan that sits on the shelf and gets dusty, but making it real every day, incorporating it into what you do every day across your organization. And how do you gain that synergy? Jennifer, I think I heard you talk about cascading goals down into the department and having different weight attached to those different goals. I think that, that speaks very well to what's one way you can align goals across an organization. Can you speak to that a little bit more about a process as to how do you incorporate that into your daily operations? I mean, do you look at your goals every month? Do you review them every 90 days? What does that look like?
Yeah, absolutely. So how we kind of do that across the organization. So of course, then I meet with my CEO monthly. We go over kind of my scorecard, action plans, or what my focus specifically would be, kind of rolling out with the nurse directors. If it's specific, like let's look at like service for an example. Right. If we're breaking down kind of those service scores, and then we look at kind of an area that we want to strengthen, and then we kind of set an action plan around what we want to do to kind of strengthen that specific HCAP category. And so then I would just kind of go over with him kind of the plan, make sure that he agrees, and then we would roll that out. And so then underneath me, my directors, we have different kind of service ones because, ED is a different question than maybe the floor. And so then we meet as well with a one-on-one meeting every month, and we go through their scorecard and look at the action steps that they're kind of taking to meet those goals. Now with nursing, the employees, the managers go over their report with them monthly when we do kind of monthly meetings. But here at the hospital, we do a quarterly nurse kind of a town hall, if you per se, we call it the AND meeting, all nurse department meeting. So then we also go over those goals, specifically the overarching nursing goals, then each unit goal, and just give an opportunity for nurses to kind of ask questions. So that's kind of nursing side. And then we also have the big hospital side. So, where are we with all of these goals? And we do town hall meetings. We do 3 a year. We used to do 4. And it just gets a little sometimes redundant. The summer months get kind of bunched up together. So now we do 3 of those kind of spaced out throughout the year. And so then that gives the organization an opportunity to ask questions on a larger level, and to interact kind of with senior leaders at that level. So those are some of the things that we do to kind of help kind of look at those goals. And you talk about those are these big strategies, but then we also have little more focused strategic strategies, maybe around growth and certain things like that. We also kind of review those objectives. We have kind of a stoplight approach is what we do. And just where are we, you know, what things are we working on? Where are we going? And so that we're always communicating kind of with our employees.
Very good.
Mhm.
That closing that communication loop is so important with employees. And so it sounds like you've got a good process in place to do that. Julie, that may look different in your organization. And if so, do you want to share kind of what that looks like and how you align goals across your organization?
So currently, we do town halls as well. It's usually just twice a year as far as the overarching. But our strategic initiative or strategic plan, department managers were all part of that process. And actually right now we're kind of going through and just taking it chunk by chunk or pillar by pillar, I guess you should say.
Uh-huh.
And looking at that and throwing in more details and more things of what does that look like and how can we get there. We have started the doing stoplight reports as well, but we are not connected. We're not connected yet. That loop hasn't. So we're
Yeah.
working with our IT team to even get that so everyone literally can access that. So that's where we are. Except again, like I said, we're just a little bit, but we're building that, and we're not full circle yet. But you can hear it in the conversations, you know, just depending on where you are in the organization and people and their ability to see that and understand it. But like I said, we're again just a little bit behind, just kind of building the process.
And you know, and I think it's great because it shows our audience today that it really is a journey, and everybody is kind of in a different place, but definitely, you know, there's always work to be done, isn't there? For sure. So, when we look at high reliability concepts, there's an even just culture specifically. There's a lot we know around creating an environment of accountability for staff as well as the organization, in that we, you know, have moved away from this blame and shame to looking for in medical errors that get made or near misses in our organization and so forth. Creating you know, a process where we look at system design and system flaws. How have you done that in your organization, and kind of what's the process there for maybe even looking at and identifying risk?
Yep, I can take that to start with. So we do, you know, risk assessments with each unit. Each department gets it kind of throughout the whole year, but they're just kind of spaced out kind of over the quarter. Some are clinical, some are non-clinical. So some things are identified in that kind of risk evaluation. Of course, you know, Kansas is a risk management state. So we do, you know, look at like variances that get reported and really drilling into the, you know, root cause of what that was, not just, you know, the human factor, but were there systems, or did we not have something implemented? Either, you know, it could be even as simple as a competency that maybe we didn't have identified for a new hire, so they just didn't know this process. So really, you know, drilling into all details of things and looking at what we can do to strengthen kind of the organization. If we can build, you know, things, you know, prompts with like electronic medical record. We do a lot of also kind of double checking. We have house supervisors that kind of operate as our house administrators throughout the day. So they do also a lot of quality checks kind of periodically throughout the day to kind of just make sure things, you know, are operating appropriately. That was something we didn't used to do. And so these are just things that we've identified that, you know, patients admit at all different times in the day. Doctors are in and out of the organization. So just making sure we have a second set of eyes looking at things. So some things like that we do is really, you know, just drilling in to those things.
Yeah,
We do
that
have a way.
developing kind of probably that repetitiveness or some resiliency into
Yeah,
your workflows.
redundancy. Yep.
Mhm.
And then, you know, we also have a way for staff to kind of submit a request electronically just through our intranet, that maybe they see something that they also want to improve. So trying to also give them a voice, and that we can bring that back and kind of look at it. Our quality department here does an awesome job of a lot of stoplight reports, being very transparent. You know, we use kind of names when we do reports for physicians and kind of different things like that. I think just being able to kind of drill into those and have those conversations and communications just kind of helps. So,
Yeah. And Julie, in order to do that, we know there has to be this this culture of psychological safety. In order for, you know, staff to feel comfortable reporting, how did you create kind of that culture of safe, you know, psychological safety in your organization where staff feel comfortable bringing things forward?
One area that where we started kind of a heavy hitting on is on medication reconciliation and then the whole medication administration process. And so we had just throughout the organization, but specifically with throughout pharmacy and the way that we functioned, had a lot of one-offs, right? And we also had things that things didn't work right, and so it just didn't work right because it just didn't work right. So we had a lot of workarounds.
Yeah.
So we have really talked about we've had, you know, it's really the storytelling, and so when there was an issue, wait a minute, have we had that issue before? Oh yeah, and so now what we have challenged our staff with is increased reporting. So with us, our medication errors reporting, our medication or reports have skyrocketed, which kind of made my CEO a little bit nervous. But I was so excited, and my night shift
Yes.
is our rock stars. So anyway, it does make other people, but I was very excited and said, this is a good thing, and this is why.
It is.
And we have improved lots of different things. And so you see those small wins and have those, we sit down and have those conversations with my nurses, and it's really awesome. Another way that has been is with providers as well. When as far as CPOE and our EHR and yeah, having those order sets and why doesn't this work? I ordered this XYZ. When we go back, well, did you use the order set? Is the order set correct?
Yes.
All those things, and showing them, like I said, really that sit down, that storytelling, really just hearing them out. And we've had, again, like I said, those small wins, and now they come to you and say, I think we need to change X. And
Yes.
yeah,
Yes.
my heart sings inside. So those are just the small wins really in those conversations, and then empowering my nurses, or when the physician says this didn't work, then now they say, well, why didn't it work? And what can we do better? Instead of going, you got to go tell Julie.
Yeah.
So anyway, that's the best for us, just those that communication, and then we're building relationships as well.
Yeah.
I don't use the word standardization. I try not to use that. We try to hardwire things, but also what's our best practice and what's the right thing for the patient is really kind of how we always loop it back to, or this is all about the patient. This is all about the patient. Even in my EVS team, now we're doing double checking with that team as well. And it really has just, kind of turned it around and opened up their eyes. So.
Julia, something Julie kind of said there kind of reminded me, you know, you were talking about kind of the just culture tool. And one of the things that we kind of do with that is, you're right, just looking at kind of, you know, a concern that might be brought up is talking to more than just the individual that maybe was impacted, and reaching out to some colleagues and seeing, you know, is this the same practice that you do? Because, you know, it might be, you know, like we said, like our training, we might have an issue with our training, and we need to, you know, look at that a little bit differently. And then how can we, you know, change and create success within the organization by talking to multiple individuals.
Yeah. And I like that. And Julie, one thing that you said that really I think is key is in addition to that communication and relationship building, it sounds like, you know, it's a team approach to improving processes. And I think that is key, you know, involving the people who do the work. You know, not you know, the leader sitting at the top, designing the work and pushing it down, but really going to the people who do the work every day and letting them help you drive the decisions from the front line up. And I know in just talking with you both frequently, I know you both do that in your organization. And I do think that is another key. You know, one of the things that I've been kind of hearing lately that I really like is, you know, getting more upstream from in a just culture and high reliability organization. It's really getting upstream. If an event has already happened, it's too late, right? We can't prevent harm. So how do we get upstream? And one question that I liked to put out to my staff is to say, what is the riskiest thing you've done today? And they'll tell you, right? Maybe not at first because they might not be thinking in that risk lens. But or better yet, maybe asking the nurses, hey, what shortcuts did you take today? And it's okay if you tell me. We're looking for risk because we want to get out ahead of risk so we can identify it and put things in place, good, better processes, or, you know, tell me why you're doing that. So we can understand the risk, right? So identify risk, understand the risk, and then that allows us as leaders to manage the risk. Would you say you kind of have built a culture where your staff look at risk from that lens or are looking for risk? I heard that maybe a little bit.
Yeah, and I can go ahead,
Oh,
Jennifer.
go ahead, Julie.
Okay, so and yes, again, like I said, we're just starting the journey, but I do, like I said, and I start out when I do my rounding is, you know, what concerns you today? Is there anything that you have concerns about? And then what are the things that you're working on? So that is where we start out, and it doesn't matter which team I'm rounding on, but yeah, that I think that the risk lens opens up. You know, I do share stories that I ask my colleagues or ask other experts or what's everyone, you know, what are other places doing, and so I hear and see my team doing or our team doing that as well. When you go and you, like I said, ask beyond the event or whatever happened, what else is going on elsewhere. So it's not reinventing the wheel anymore and looking
Right.
at risk so that we can, like I said, get ahead of it. But
Yeah.
Yeah.
Jennifer, did you have anything you wanted to
Yeah, I
add
think
there?
it's very similar. You know, we do rounding with our staff as well, and you know, asking about, you know, tools and equipment that they need. And it's not just asking it in that way. It's, you know, what did you have to run for this week? You know, what caused you to have to step away from a patient, and what did you need to go get, and those types of things. And so kind of looking at things like that. I think one of the areas that we are just trying to start to elevate in is even kind of a different view, is kind of looking at what I maybe call more like big data, and how can we drill into some of the things that are occurring in our electronic medical record, and working more with like our IT department on, you know, what alerts do we see firing the most, or what
Yes.
things have staff overridden that they shouldn't override.
I love
because
that.
I don't think when you're having that conversation with them, they aren't thinking about that. So
That's
kind of looking
right.
at that data and then being able to kind of focus that conversation with staff. And then you can really drill into the why. What caused you to do this? You
Yes.
know, did you just not have, you know, the right armband on the patient, or I don't know, kind of hypothetical, the barcode of the med didn't work right, you know, so you can kind of drill into some things more that maybe you wouldn't have uncovered with just the conversation. So kind of looking at it at a bigger level where we're trying to, so.
Yeah, and you know, we have a question that popped up, you know, is from Mandy, and I was just getting ready to ask that same question. Mandy was, you know, first of all, do you track rounding? And one of the things that was, you know, one of my questions was going to be, do you track and trend if you do safety rounds or, you know, risk rounds, whatever you might call them, safety huddles? Do you track and trend and act on and, you know, kind of keep track of those and then act on those. And Jennifer, I kind of heard, it sounds like, you know, you are trying to get at some of those things. And I think that's a great way of doing it, is looking for those types of things in your EHR to alert you to where some of that risk might be. Julie, do you have, you know, safety huddles as well? Do you do some of that? And if so, is it a little bit different, or how is it different?
So our safety huddle, we do have an entity huddle, and it's just once a week. And then each unit does their own safety huddle, depending on when that works for them, either once or 2 times a day, depending on when they are off shift and change shift. As far as the rounding, like I said, our leaders are rounding, and then on our employees, and then we are doing patient rounding as well. Most of the tracking on the rounding, what we've been doing is trying to track it within the stoplight report that is department specific. Again, like I said, we're on our journey. And so the goal then is to get that into an entity stoplight report where you can kind of track that. But that's really the only spot that we're tracking it now. We can share our stoplight report. Our stoplight report is based upon what Huron utilizes and what they have shared with us, and it's pretty simple, just a red, green, and yellow. We've got it, and we've got it in a Word form, and we have it in an Excel form. But we're looking at moving to a different platform for Microsoft, so we can share that just in real time and update it. So that's where we are currently. And then if I round on my teammates, I keep notes. But that's, and if we do see something that is an incident or something we know we want to report and track, I encourage people to put that in the QDC, and that's where we just try to keep all that safety risk there. So.
Good.
I was just gonna jump in there a little bit, because we do it a little bit differently. So we have what we call like a hospital-wide safety huddle. So all clinical departments are on a call, and it's led by just kind of a Teams call every morning at 8:50. I lead that call. And so it's all of the nursing departments, all of the clinical departments, several of our senior leaders, and it's open to any manager that they can get on and off. Even our EMS department reports out. And so we go through, you know, just general kind of safety items. We just do an overview of kind of census of the day. We talk about like EMS trucks, how many are available for like transfer for the day. Pharmacy is a huge component of that. If we're looking at, you know, meds that are maybe going to be on short supply, or different kind of things coming. So everybody in the whole organization is aware of those types of things. Environmental services reports off. We have biomed that's on the call that kind of talks about projects of the day. Environmental services, if there's something that maybe we're repairing or working on that people need to know. So it is a big meeting, but it doesn't take very long. It takes about 10 minutes to kind of get through all of that information. And then that can even kind of roll down to departments, and they can kind of share that information out kind of with everybody. So that's another way that we also do it, to just engage that communication within our whole hospital.
Nice. You know, one thing I will point out too is Just Culture. When I first started looking at Just Culture, I really thought of it more as, you know, kind of a clinical thing, if you will, and how we looked at, you know, errors, medical errors and incidents and so forth. There are tools out there, you know we probably have all seen. And if there's people on the call today that, you know, would like some tools, we can certainly do that. That wasn't one of the things we were going to focus on today. But I will just say quickly, in looking at tools, we want to make sure that we not start with human behavior. If you have a tool that you're using to help you in that Just Culture decision making, you know, make sure your tool does not start with human behavior. You want to start with system. And I think I've heard Jennifer and Julie both speak to today how they kind of do that in their organizations. But I wanted to just highlight that, and the fact that Just Culture is not just for clinical departments. It is the entire organization. You know, I can think of cyber risks. You know, those are risks that impact patient care. So if your EHR goes down, obviously that impacts safety. So just culture, it's so much more than just a clinical department thing. It is really organizational. So moving on then, can you both speak to sustainability just a little bit, and how do you sustain this culture of safety, or, you know, develop that infrastructure for sustainability? Jennifer, maybe you can jump in first.
Yep, absolutely. You know, a lot of sustainability, I feel over my, 10, 20 years I've been doing this, probably broke all the rules at first. And I really feel like it's validation tools. So, it's time consuming, some of these projects that you're rolling out. But what's really more daunting is you roll it out and then you don't validate the behavior and it doesn't stick. So, putting that time commitment in to actually having a validation tool, some of those are things that we also worked with kind of Huron. And so they've had maybe a validation tool that we could use, or that we customize that. We do, for example, like bedside shift report, and we do that a little differently than everybody else because we want them actually in the computer software and going through certain things.
Right.
So when we're, going at the bedside and we're validating that behavior, we're making sure that they hit all those things. So we've taken that tool and modified it to what our expectations are for our organization. Now, I will tell you, validation is time consuming. So that is probably, an area that we also could get stronger in as well, because to follow a nurse and evaluate that behavior, or a staff member and evaluate those behaviors. And we also kind of, before we even do that, we usually start with like a clinic and kind of show them what right looks like. And so it's just a time commitment. And that's probably the hardest thing with validation.
Yeah. Julie?
I would wholeheartedly agree with what Jennifer said. And I guess, and where I have to remind myself, over and over is celebrating the small wins. So with with the validation, celebrating the small wins, and so you can, eventually get to your end goal. But I think Jennifer hit it spot on. So I don't have anything else to add.
Yeah, and as a quality of improvement advisor, and even in my own experience as a chief operating officer over clinical departments, that validation piece was crucial. But as you said, it can be the thing that we miss in clinical operations. We're good at kind of putting things into place, and then we forget to develop the audit side to track and trend how well that initiative is going. Is it working? Is it not working? And so closing the loop and making sure when we implement something where we have a way of measuring the effectiveness of it, I think is so important. And then just real quick, as we start to wrap up, is there, maybe share one or two challenges that you've had along the way?
Yeah. So, I am only kind of oversee most of the, nursing clinical operations. So I think one of the challenge that we have is sometimes moving all divisions kind of at the same level. So, like most of you, you probably have kind of heard of the acronym like AIDIT. It's something that we use here, and I think we do an excellent job at it. But we've had to even kind of, over the course of 15 years, kind of pause and then go back and train that, because, we've had new leaders. And so maybe they didn't hear it as it was kind of, brought in. And we have so many new staff members that on board, every month. And so taking a pause point to say, okay, yep, we've already rolled that out, but now we're going to have to roll out that information. And again, that's kind of time consuming. And so for a small rural critical access hospital, that those resources to be able to do that, there's, competing events. So that's probably an area that is kind of a challenge.
Are those things that you put into your orientation of new hires?
Yes,
as well?
We do. But, when it's either just onboarding and they've only been here for a few days, it's a really high level. And so now then after they've been here, I think what an area we could approve is in, 90 days, then let's break it down and then look at those validation behaviors. And so different kind of things like that. But sometimes there's just not enough resources to get those other things implemented because something else has a competing thing.
Yeah. Julie, do you have anything to add there?
My only add, and I would agree with Jennifer, those are some opportunities that we are working through as well, is that at a critical access hospital, when we in a smaller or in a smaller organization, we have the opportunity to make changes happen quickly. And
Uh-huh.
if you work or
Yes.
worked for a larger institutions, you would probably think, oh, that's awesome. And it is very awesome, but also sometimes we can jump too quick. And
Uh-huh.
and then we get ourselves in trouble. So I think that is one also. And with
Mhm.
that, you can also you all of a sudden you have more than maybe two great initiatives that you're working on, but you're working on multiple, and then none of them really
Yeah.
do very well. So I think that's a challenge in a smaller arena or smaller rural hospital or entity. But also therein lies the challenge that healthcare is changing all the time. So you have to keep up. I think the
Yeah.
only other challenge that I would say is that we also are all working on the same thing. And I think this, like I said, I've worked in Kansas now for 2.5 years, and the rural hospitals, I guess, support for quality and nursing and even beyond is so awesome. So don't shoot yourself in the foot, reach out. And I think that's the greatest thing that you have to remember is um, someone else is working on the same thing you are, and it
Yes.
share. And so I think that would be my it's not a barrier, but sometimes you forget, and you are in your office beating your head against the wall and think, no, wait,
So true.
call someone. So anyway.
Yes. Well, thank you both for sharing, your journey with us today. I think it's really these types of conversations that's going to help us continue to garner what's needed to strengthen culture, our knowledge, continue to create those learning environments that we know are so important to really get to high reliability in our organizations and create that culture of safety to ensure that, our care is it's safe, it's timely, it's efficient, it's equitable, and it's overall just patient-centered with every patient every time. So, Kim, I'm going to turn it back to you.
Sure. Thank you so much. I want to make sure that anyone that has other questions, that you have an opportunity to get your question answered. You can do that by either clicking the raise hand button or typing in the chat box, or honestly just unmuting your line and shouting out your question here. Real quick, as you're thinking of those though, I was really struck by this conversation and for all of your approaches to reliability here, that it's a very people first approach that you all are taking. It's really common to hear from organizations to say, we're on a high reliability journey. Now we're going to become an HRO. We're doing like it's a whole separate initiative. But the way that you described just implementing high reliability principles into the people it really was I think a game changer in the way that you approach team members and say, be open and honest. What workarounds did you have to do today? Understanding that there's a system in place that allows for those kinds of things to have to occur. And so as an organization that's moving towards reliability and always think of it, we're looking at our people first and then moving down. I think that's fabulous. And I'm curious because both of you also said that you don't use the term high reliability, or you don't, that's not really, the language is a little different too. And I'm wondering if changing the language was purposeful or just a happy accident that folks don't think that, oh, great, here's just one more initiative that we're doing. Can you speak to the language that's used with your teams for this and how that might have affected their wanting to participate in this kind of an approach to safety?
Yeah, I can. I just think our staff when you say high reliability organization, what does that mean? And so our staff really more relate to it as, providing excellent care to our community members. And so what causes a barrier to providing that care. And when you're talking with them, you're looking for, standardization in work, or, lack of tools or resources, or lack of understanding. And so I think you just want to put it where staff members can truly relate to the purpose and the work that they're doing. And so I think it's just phrasing it in a different way that, we have, for example, like a standardization with policies. All of our policies are document controlled. And so they have to be printed every single day if you're going to use it. So we don't always say, how do you know how is your document control? Show it, show us where, how do we look at this? So you might have to phrase it in a different way that they can understand, because they just don't maybe understand the terminology.
I like that too. It helps everyone to understand their role in building reliability too, and maintaining and sustaining reliability. Love it.
Yeah, and I would add on a little bit, even when I have utilized the words high reliability organization, which is hard to say really fast. With my exec team, everyone kind of glazes over a little. And so, but when we dig into the principles and say, we're there, we've got some great building blocks, and here's what we can do to move forward. It's making it personable, and bringing it right back to the care and the patient. So it's just that, and I have worked at a place where we utilized the word and it became a checkbox. It really was. And so, and that didn't feel good. And so, that's where I live. And that's why, like I said, that's how our journey has started and why.
Wonderful. Incredible lessons learned here. Any other questions from the field? You can unmute your line if you'd like. Okay, well, we are.
I have a question, Kim.
Good. Hi, Christine. Yes.
Oh, thank you. This is Christine Lurek from Telegen. I'm a geriatric physician by background. I think I literally am a geriatric physician now,
You
but
are not.
that just occurred to me. So when I look at the principles of HRO, I think the reluctance to simplify might be maybe one of the more challenging because of human nature, and it seems overwhelming. Can you speak to maybe some examples of how you tackle that one?
I can start as far as reluctance to, so I think that as a leader, you have to be able to look at the big picture, and then, like I said, bring in the right team members, and really let them be able to control or provide input on what is important to them, and then what is their role, and then be able to say, this is hard, because it is hard. And so I think that is where that's where anything where you're within high reliability organizations and within change, when you're doing any kind of a change or improvement, it's letting everyone say, this is hard, I don't think I can do it. Okay, so now, but this is where we're at. This is our reality. And now what do we do with that? So anyway, and then you've got to, let's say, okay, here's our goal, here's our stretch goal. And then how are we going to, like I said, how are we going to validate and keep going? So that's really where we meet that challenge. And there's probably beyond that, but that's where we're at.
Yeah, I'll add just a little bit to it. I feel like probably we have a patient safety council, and that is a multidisciplinary group that meets once a month. So it's nursing, it's quality, it's risk, it's department directors, kind of throughout the hospital. And probably that is the group where really the true HRO principle or accountability resides in, so it's the team that we're, drilling into errors more specifically, you know, if we're looking at, I think Julie was talking about kind of like her variance system or reports, you know, and looking at it in a broader view, you know, what's a category that we need to focus on that we're seeing kind of some trends or behaviors around. And so that, you know, persistence or, you know, preoccupation with failure at that level is kind of where we are. And then kind of rolling it out to staff, if we're seeing kind of workarounds that we just don't find acceptable, you know, you have to recognize that we are in the work of humans. And so, you know, each patient has maybe a little different variable that you have to do, but we don't allow for certain workarounds, like Julia's talking about medication safety. So making sure you're scanning the patient, making sure you're scanning the med. So that team also looks at, you know, those numbers and what caused a concern where we couldn't do that. So not always are we rolling out all of those principles to staff. There is kind of this overarching group that's looking at it on a higher level, and then just kind of explaining to staff members when we're talking about those types of things, the why behind it. And it's always for, you know, patient safety, for improved clinical outcomes, for improved clinical care. And so they can relate to those things. So I don't know if that kind of helps.
And real quickly, I would add in that reluctance to simplify, I think it's just important to, it's our human nature to jump to solutions right away when there is an issue. And so really forcing ourselves to spend time gathering information and not making assumptions. So really taking time to explore, be curious, ask lots of questions before we get to a solution. And to me, I know Jennifer and Julie both do this in their practice, but to me, I think that is what is really important in that reluctance to simplify realm.
Right.
That
So
was
helpful. Thank
a
you.
Thank you. And what a wonderful way to wrap up this
Yeah.
session today. I know we are at time here, and I just want to thank you all so much for sharing. This was really, really a great way to reframe, I think, how a lot of us think about high reliability and the implementation of it in our hospitals. So thank you so much. We will be sending out slides and recordings, and there are a couple of examples of resources or tools or resources that were requested. We'll get those out to you next week. And we'll also send a link for the full HRO day recordings so that anyone who missed those will have the, you know, access to all of those too. And as we all move along together on this ongoing journey that never ends, it's a verb, not a noun. And appreciate all that everyone does for the care of the patients that we serve. So thank you so much and have a wonderful rest of your day. Thank you.